Hello, my name is Oliver Chen and I'm a rising senior at Solon High School. This summer I was given the opportunity to work in the respiratory therapy internship in the Respiratory Institute. The title of my project was Biomarkers and the Prediction of Severity of Sepsis in the MICU. The focus of my study was the prognostic value of procalcitonin, white blood cell count, and lactic acid as biomarkers in predicting severe inflammation known as sepsis. So what exactly is sepsis? Sepsis is a serious medical condition caused by an overwhelming immune response to infection. The infections first cause widespread inflammation and then impaired blood flow, which in turn damages the body's organs by depriving them of nutrients and oxygen. Any patient can become septic because sepsis stems from another infection in the lungs, skin, or any other organ. Sepsis can be caused by bacteria, virus, or fungi, but is most commonly caused by bacteria. In addition, an invasive procedure such as a vascular catheter can introduce foreign bodies into the bloodstream. Sepsis tends to target children and the elderly. Severe sepsis strikes about 750,000 Americans, which is about 1 to 2% of all hospitalizations. It is estimated that between 28 and 50% of these people die, making sepsis one of the most common causes of death in the ICU. To diagnose patients with sepsis, doctors will perform an exam and run tests to look for bacteria in the body fluids such as urine, the source of infection using imaging, a high or low white blood cell count, a low platelet count, or low blood pressure. Then the physician will treat the patient with a combination of broad and narrow spectrum antibiotics or other medication to help fight the original infection. Many patients receive oxygen and intravenous fluids to maintain normal blood oxygen levels and blood pressure in addition to medication. Depending on the gravity of the infection and resulting conditions, sepsis can be categorized into 4 distinct severities. The least severe stage of sepsis is known as systemic inflammatory response syndrome, also known as SIRS. SIRS is defined by having 2 or more of the following symptoms: abnormal temperature, heart rate, respiration rate, and white blood cell count. The next step up in severity is called sepsis. Sepsis is diagnosed if a patient has a confirmed case of SIRS, which I just mentioned, or either a known or suspected infection. The next step is called severe sepsis. Severe sepsis is diagnosed if the patient has a confirmed case of sepsis and organ dysfunction in 1 or more of the cardiovascular, renal, respiratory, hepatic, hemostasis, or central nervous systems. The final and most dangerous step in sepsis is called septic shock. To diagnose septic shock, severe sepsis must be confirmed and the patient must have refractory arterial hypotension, more commonly known as low blood pressure, that cannot be corrected with any type of medication. The first biomarker I studied for my project is procalcitonin, or PCT for short. Procalcitonin is a 116 amino acid peptide precursor of the hormone calcitonin involved with calcium homeostasis. When a bacterial infection is present, PCT levels can increase up to several thousand-fold. Interestingly, PCT levels do not increase noticeably with viral infection or conditions such as burns or trauma that also cause systemic inflammation. This characteristic gives PCT value in diagnosing a bacterial infection and sepsis as opposed to more general systemic inflammation. In a lit search, I found that procalcitonin can be used as markers of sepsis and generally grades well with the degree of sepsis. The second biomarker I studied was white blood cell count, or leukocyte count. As you probably already know, white blood cells are cells of the immune system that are concerned with the defense of the body against both infectious disease and foreign materials. This count rises in a non-immunocompromised patient in the presence of an infection. However, this biomarker cannot distinguish between bacterial, viral, or fungal infections as well as PCT. A high or low number of white blood cells in the blood is often an indicator of disease. The third and last biomarker I included in my study was lactic acid, a carboxylic acid. Lactic acid loses a proton when in a solution to form the lactate ion. Lactic acid is commonly associated with the sore feeling after exercising strenuously and is constantly produced from pyruvate via the enzyme lactate dehydrogenase in the process of fermentation during normal metabolism. A lesser-known fact is that levels of lactic acid get higher when a severe infection such as sepsis or septic shock lowers the flow of blood and oxygen throughout the body. So after researching the background information and performing lit searches, I created 2 research questions that I would attempt to answer through my project. The first was, because sepsis is a constant lethal danger in intensive care units, which of the 3 biomarkers, PCT, white blood cell count, and lactic acid, is the best predictor of the severity of sepsis? The second question was, which of the 3 biomarkers can most accurately predict the presence of sepsis in MICU patients? The 2 questions may sound quite similar, but the first concerns the severity of sepsis, while the second concerns solely the presence of sepsis, not necessarily the severity. I hypothesized that yes, there is a difference between PCT, white blood cell count, and lactic acid level in predicting the severity of sepsis, with PCT having the strongest correlation with the severity of sepsis. I also hypothesized that of the three biomarkers, PCT is the most accurate in predicting the presence of sepsis. This study was a retrospective observational study carried out with the medical intensive care unit patients. All of the data was retrieved through the Epic Care database and the Critical Care database. The exclusion criteria for the patients was that every patient had to be 18 years of age or older. The inclusion criteria was that all consecutive patients hospitalized in the MICU with an anticipated stay of more than 12 hours were included in the study. In the study, each observational unit was not actually each patient, but rather each day that any patient stayed in the MICU. In other words, if patient A stayed 3 days in the MICU and patient B stayed 2 days, I would have a total of 5 days as my sample size. My sample size ended up being 91 days of data collected from a total of 36 patients from the MICU. The mean age was 59.5 years of age, and 16 of the 36 patients were female. Moving on to the data, it is easy to see that a large majority of the patients were male, and most patients stayed only 1 to 2 days in the MICU. So this is what a small portion of my final clean data table looked like. The unit for white blood cell count was 1,000 per microliter, the unit for lactic acid was millimoles per liter, and the unit for PCT was nanograms per milliliter. The sepsis variable was a categorical variable and therefore had no quantitative unit. Thus, I created a simplistic numbering system for the severity of sepsis. I assigned a patient with no infection or inflammation a value of 0. A patient with SIRS received a value of 1. A patient with sepsis received a value of 2. A patient with severe sepsis a value of 3. And finally, a patient with septic shock a value of 4. The values for every variable, as you can see, can vary quite largely. Here's a graphical distribution of the severity of sepsis of the sample size. Most patient days had no infection or inflammation. With the severity of sepsis as my dependent variable and PCT, white blood cell count, and lactic acid levels as my independent variables, I ran a Spearman correlation coefficient statistical test. The Spearman correlation coefficient was calculated to evaluate the strength of each of the associations between the severity of sepsis and the predictor variable. A value of the coefficients very close to either 1 or -1 indicates a perfect positive or negative correlation between the predictor and response variables, while a value of 0 indicates no correlation. Because PCT, white blood cell count, and lactic acid levels had a correlation coefficients of 0.57, 0.48, and 0.36 respectively, the independent variables all had a medium strength positive correlation with the severity of sepsis. Interestingly, the p-value of all three biomarkers were significant. To get a visual idea of the actual distributions of each biomarker and their relationship with severity of sepsis, I included several scatter plots. After performing the Spearman correlation coefficient test, I ran a simple logistic regression analysis for each of the independent variables. I used this to evaluate the actual presence of sepsis, not the severity of sepsis. By dichotomizing sepsis, I could test the relationship between the biomarkers and incidence of sepsis. By dichotomize, I mean that the 4 levels of the dependent variable were combined into inflammation, meaning that SIRS, sepsis, severe sepsis, and septic shock were all combined. Therefore, the severity of sepsis was not included in the statistical test. The white blood cell count and lactic acid were found to be statistically significant, while PCT was found to be insignificant in detecting the presence of sepsis. The results show that all 3 biomarkers had statistically significant positive correlation with increasing severity of sepsis. Therefore, I concluded that all 3 biomarkers show a medium-strength positive correlation with the severity of sepsis, with procalcitonin having the strongest association. After dichotomizing the dependent variable into no infection and systemic inflammation/sepsis, and running simple logistic regressions for the 3 biomarkers, I concluded that unlike the other biomarkers, PCT levels are unable to accurately predict the actual presence of sepsis. After analyzing the results, the 2 separate tests seem to show contradicting results. However, even with the multicollinearity of the 3 variables, these results can hold value. I concluded that the Spearman correlation coefficient suggests that PCT is the best biomarker at differentiating between the severity of sepsis, but the simple logistic regression tests show that it is the weakest indicator of the presence of sepsis. Therefore, my first hypothesis that PCT was the best biomarker at predicting the severity of sepsis was proven correct, but my second hypothesis that PCT was the best biomarker at predicting the presence of sepsis was incorrect. A recommendation for future studies. Demographics should be considered more strictly because many age groups and races, were underrepresented. Second, severity of sepsis was assigned numerical values of 0, 1, 2, 3, and 4. These values indicate that the difference between each level was equal, but this is obviously not true. Septic shock is not necessarily 4 times as severe as SIRS, and therefore the numerical values do not hold a precise measure for the actual severity. A more accurate and continuous quantitative scale must be developed. Lastly, some patients had a greater effect on the data than other patients did because each patient was admitted for a variable number of days to the MICU. In the future, each patient admitted to the study should have the same weight on the experiment as the others. I would like to thank the following people for their tireless efforts to make the study possible. To my mentor, Connie Cottrell, Drs. Madhu Sassitar and Jorge Guzman, Nedra Starling, and the Office of Civic Education Initiatives. Thank you.